Bismillah ar-Rahman ar-Rahim. Our topic now is bronchogenic carcinoma, and by definition it is the primary tumor of the lung arising from the respiratory epithelium, either from the bronchi, respiratory bronchioles and alveoli. As regards the incidence and the prevalence, bronchogenic carcinoma is the leading cause of death all over the countries, and squamous cell subtype of bronchogenic carcinoma is the most common, which represents from 30 to 50%, followed by adenocarcinoma, large cell carcinoma, and small cell carcinoma. Risk factors for bronchogenic carcinoma are many risk factors responsible for the bronchogenic carcinoma, especially cigarette smoking and occupational associations as asbestos, and other factors include pollution, and tuberculosis is considered as predisposing cause for bronchogenic carcinoma, which is called scar carcinoma. The relation between lung cancer and smoking: about 90% of lung cancers attributed to smoking. However, only 20% of smokers will develop lung cancer in their lifetime. And of course, risk decreases with stopping of the smoke. This is one of the most famous American actors, which used to share in the advertisement for this brand of cigarettes, and unfortunately he died of bronchogenic carcinoma. Bronchogenic carcinoma can be classified into central lung cancer, in which is a tumor originating at the close to the hilum of the lung, or peripheral lung cancer, and according to the histological classification, into small cell lung cancer, which is the most aggressive type, and non-small cell lung cancer, which include squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. From the clinical point of view, bronchogenic carcinoma can be presented by any of the signs or symptoms of the respiratory system, from cough, expectoration, hemoptysis, wheezes, atelectasis. These are due to primary lesion, the tumor itself, or even the local extension of the tumor to the surrounding structures. And I would like to stress on the idea that about 5 to 15% of patients are asymptomatic when discovered to have bronchogenic carcinoma. And this small percentage of patients are who are discovered accidentally, either by routine chest X-ray examination or screening. And they are the only patients who have the hope for curability from the disease. Also, manifestations of the spread to the hilar and mediastinal lymph nodes, and the compression of these lymph nodes. Also, superior sulcus syndrome, or Pank's tumor, is a tumor which is arising above the apex of the lung, and it is manifested by special manifestations different than bronchogenic carcinoma due to the affection of neurovascular bundles of the upper limb. So the presentation is usually related to the upper limb by numbness with pain and the swelling of the upper limb. Also, clinical manifestations can be related to the extrapulmonary manifestation due to metastasis, as well as paraneoplastic syndromes. By physical examination, you can find all these findings due to the tumor or extension of the tumor to the surrounding structures. Now, how to reach the diagnosis of bronchogenic carcinoma? If you suspect a case of bronchogenic carcinoma, how to reach the diagnosis? First of all, we need to know the steps of investigations and the aim of the investigations to be done. Number one, to detect if there is any tumor or no tumor. Number two, to establish the cell type, which type of bronchogenic carcinoma, either squamous cell, adenocarcinoma, small cell, or large cell. And finally, to define the stage of the tumor, because the stage of the tumor control the strategy of treatment of this specific stage for this tumor. For suspected cases of bronchogenic carcinoma, the first radiological examination to be done is the plain chest X-ray of the chest. And this is an example of a plain chest X-ray of the chest, which shows in the left panel there is a coin shadow in the left upper zone of the lung, and in the right panel this is a lateral chest X-ray view, which show that the tumor is lying anteriorly, peripherally. This is another presentation of bronchogenic carcinoma in plain chest X-ray, which shows the total opacity of the left hemithorax with mediastinal shift to the same side, which denotes that there is obstruction of the left main bronchus by the tumor, leading to collapse of the left lung. Another presentation of bronchogenic carcinoma is the lung abscess, which is lying in this X-ray in the left lower zone of the lung with horizontal fluid level. And the mechanism of developing lung abscess in bronchogenic carcinoma is either due to big size tumor and central necrosis, or even due to obstruction and infection distal to the obstruction in the lung, leading to lung abscess. Alveolar lung cancer is a special entity of bronchogenic carcinoma, which is present as it shows in the chest X-ray and CT scan by picture looks like pneumonia, and sometimes it is bilateral and is very aggressive. This is a CT scan of the chest showing the peripheral bronchogenic carcinoma. Another CT showing the hilar or central bronchogenic carcinoma. After radiological examination, there is endoscopic examination, which include bronchoscopy, mediastinoscopy, and VATS, which is video-assisted thoracoscopic surgery. Usually we use the fiber optic bronchoscopy as it can reach to the segmental bronchi to detect if there is any endobronchial lesion. And we can take a biopsy either by punch, forceps biopsy, or even brush cytology or bronchoalveolar lavage. Also, we can take transbronchial lung biopsy if the tumor is not endobronchial and it is outside the bronchus, and compressing the bronchus, and from the anatomical site of the tumor we can use the transbronchial needle lung biopsy. And this is the technique of fiber optic bronchoscopy, how to be performed when the patient is lying down. This is the extent of extension of the fiber optic bronchoscopy, how it reaches the segmental bronchi. This is the second endoscopic investigation, which is mediastinoscopy, and this is rigid one, and pass through the incision suprasternal notch and in the pretracheal fascia, extending to the mediastinum to detect if there is any mediastinal lymph nodes or extension, and you can take a biopsy from this lymph node. VATS, which is video assisted thoracoscopic surgery, if all other investigations failed, so have to do VATS and go through the thoracic cavity and take a biopsy under the vision of the camera using a forceps, and you can take biopsy or either punch or segmental excision or nodal excision. Thoracotomy, small thoracotomy is the last investigation to be done by small thoracotomy, opening the chest and take a biopsy if all other methods failed to reach the diagnosis. In some circumstances, a histological diagnosis can be made by biopsy of metastatic sites such as lymph nodes, especially in the neck or axilla, and liver, bone, or bone marrow. Non-small lung cancer is classified according to NM classification, in which T means tumor, N means lymph nodes affection, and M is metastasis if it is present. However, small cell lung cancer is divided into limited and extensive stage, because once you diagnose the small cell lung cancer, in most of the cases it is already metastatizing. This is a T, which means the tumor is classified into T1 to T2 and T3 according to the size of the tumor, and also T4. As well, lymph node affection is classified into N1, N2, N3 according to the identification of H1 in this slide. Distant metastasis either present or absent, so M0 or M1. As we see here, we can stage the tumor according to the 10M classification into stage 1, A and B, stage 2, A and B, stage 3, A and B, and stage 4. And as we mentioned, then this TNM classification is not suitable or not an ideal for small cell lung cancer. Why the lung cancer has a poor prognosis? Number one, because usually it is developed in old age patients. Second, that presentation is often after the patient becomes symptomatic, is in stage 3, and this stage has a poor prognosis. Also, successful surgical resection and cure are only possible at early stages. And for example, in the United States, only 20 to 25% of newly detected lung cancer is stage 1. Treatment options for bronchogenic carcinoma include surgical resection, chemotherapy, radiotherapy, or combination of surgery and chemoradiotherapy. Also, there is some other therapies as immunologic therapy. Now, what are the surgical options for bronchogenic carcinoma? Number one is open biopsy, and this is used for diagnosis. Number two, pulmonary resection, which means one of the following: wedge resection, segmentectomy, lobectomy, bilobectomy, and total pneumonectomy. And finally is the lung transplantation. So what does we mean by wedge resection and segmentectomy and lobectomy? Wedge resection means resection of a part of the lung without respect to the anatomy. And this is used for diagnosis also, or for resection of peripheral pulmonary nodule. Segmentectomy means removal of a segment with respect to the anatomy of the lung, which means removal of the segment with a feeding bronchus and segmental artery and vein. Lobectomy means removal of one lobe of the lung. Bilobectomy, removal of two lobes of the lung from the right side. And the total pneumonectomy, which means removal of the whole lung. For non-small cell lung cancer, stage 1 and 2 are considered candidates for surgical resection, while stage 3 may be candidates for surgery with post-operative radiation of the mediastinum. More than 90% of small cell lung cancer has often metastatized at the time of diagnosis. So these patients usually adopt radiation therapy or chemotherapy before surgery if it is possible. We must measure the pulmonary function before surgical therapy to detect if the patient can stand the operation, especially if you are going to remove one lobe or two lobes or one lung. These are the details of surgical interference of different stages of the tumor. Thank you very much, but I have two questions for you. The first question is this, and the question is: which of the following statements does not describe a feature of small cell lung cancer? Most patients are smokers. Abundant mucin production is associated. Paraneoplastic syndromes are associated. A majority of cases have neurosecretory type granules. So what is the answer here? It is B, because all these statements are right, but abundant mucin production is associated in adenocarcinoma. The second question is: a patient presented with a 3 cm solitary small cell lung tumor in the right upper lobe of the lung. Results of other imaging studies are negative for metastatic or nodal disease. Mediastinal biopsy specimens are non-diagnostic. Which of the following statements about management options is false? Surgery is contraindicated. Chemotherapy has a role. Radiation therapy may have a role. Concurrent chemo radiation therapy is an option. Now here is, although it is a small cell lung cancer, but it is a small tumor and there is no metastatic dissemination of the disease, so there is surgery is contraindicated is a false answer for this question. And this is the end of the lecture. Thank you very much.